So good morning. So my talk is on the pulsating puzzle, danger at the crossroads. So this is a challenging case with a twist at the end. So my patient was a 28-year-old CRPF Jawan who presented with redness of the right eye of 10 days duration. He was being treated as conjunctivitis at multiple places. He gave a history of RTA 2 months ago with head injury and multiple skull bone fractures, but at that time there was no ocular related injuries. On examination, he had all the visual parameters were all within normal limits with 6/6 vision, except for a mild periorbital fullness and a 3 mm axial mildly pulsatile proptosis on the right side, which is evident on the by the Navziger's method on the right hand side. On examination, you can see the dilated and tortuous episcleral vessels, which is called the arterialization of the episcleral veins throughout. The intraocular pressures, fundus, everything was within normal limits. There was no bruit, but on inquiry, he said he could hear a mild whooshing sound in the head. So, provisional diagnosis of right traumatic carotid-cavernous fistula with pulsatile proptosis was made. So, what's a carotid-cavernous fistula? As you all know, it's an abnormal communication between the carotid artery, usually the internal carotid artery, and the cavernous sinus. So, here you can see the cavernous sinus is the intracavernous segment of the internal carotid artery. You can also see the superior ophthalmic vein and the inferior ophthalmic veins draining into the cavernous sinus. So here what happens is that when there is a communication between an artery and a vein, the low pressure venous system now becomes a high pressure system, so that there is dilatation of the draining veins and venous congestion in the drainage areas. So there are different classifications. Barrett's classification is the most accepted, where type A is called the direct fistula, where there is direct communication of the internal carotid artery into the cavernous sinus. In all the other types, which are called the indirect fistulas, the communication is with one of the meningeal branches of either the internal carotid artery or the external carotid artery, or both with the cavernous sinus. So etiologically, it can be traumatic, which is usually high flow, occurs in young males after an RTA usually, or low flow spontaneous, which are usually low flow fistulas, where there be pre-existing arterial weakness, common in elderly hypertensive females or arterial aneurysms or other syndromes where there can be arterial weakness. So we did a CT angiogram for this picture. We can see on the right hand side there is a huge dilatation of the right cavernous sinus with all the engorgement of all the dilating tributaries, and also you can see the hugely engorged superior ophthalmic vein and the inferior ophthalmic vein. So our patient was a case of direct CCF, and he was advised to do the gold standard of investigation in this case, that is a digital subtraction angiography. So what is it? In DSA, what we do is a catheter is introduced into an artery, into the vessel, and a dye is injected and serial X-rays are taken. And all the other masking structures like the bones and the soft tissues are digitally subtracted, so that we get a high resolution image of the vessels. But due to financial constraints, the patient did not turn up. But 1 month later, he presented with diminution of vision of the eye, with increase in redness. At that time, the vision had dropped to 6/12 and the intraocular pressure had increased to 24 millimeters of mercury. And the fundus showed temporal disc pallor, which was evidence of optic disc ischemia and dilated and tortuous veins due to the venous congestion, and the optic disc ischemia was confirmed by the osity of the optic disc. So now it has become a direct CCF with pulsatile proptosis, secondary glaucoma and optic disc ischemia. So now it was a vision threatening condition. So at this time, he agreed to do the DSA. So while doing the digital suppression angiography, not only there was immediate leakage of dye into the cavernous sinus, this was something interesting called the steel phenomenon. So this was the crossroads I was talking about. So you know the circle of Willis. It is formed anteriorly by the internal carotid artery. That is, after emerging from the cavernous sinus, the internal carotid artery gives off the anterior cerebral artery, which communicates with the opposite side through the anterior communicating artery. Then it continues as the middle cerebral artery. Posteriorly, it is formed by the two vertebral arteries, which gives off the posterior cerebral artery, which communicates with the MCA through the posterior communicating artery. So in a crossroad, you know, you can go in any direction. The same thing happened here. So what happened here was, as soon as the blood was entering into the internal carotid artery, the blood was leaking immediately into the cavernous sinus. So there was no blood to supply the right ACA and the right MCA. So what happened was that the right ACA was actually stealing blood from the left ACA through the anterior communicating artery, and the right MCA was stealing blood from the posterior circulation through the posterior communicating artery. So this was evident on doing the DSA. So on the left hand side, this is the DSA done with the catheter on the right internal carotid artery. You can see that as soon as it enters into the right internal carotid artery, it was leaking out. there was no filling on the right hand side, there is no filling of the right ACA or the MCA. But at the same time, when the DSA was done with the catheter in the left internal carotid artery, you can see there is not only filling on the left ACA, there is also filling of the right ACA through the anterior communicating artery. So the right side was stealing blood from the left side. Then again the DSA was done with the catheter in the left vertebral artery. This is the left vertebral artery. And you can see not only there is filling on the left hand side, more than that the blood was actually flowing more to the right hand side. That is, through the left vertebral artery there is filling of both the posterior cerebral arteries, and then through the posterior communicating artery the right MCA was stealing blood. So here you can see the entire right half of the brain was stealing blood from the left half of the brain more than the left side. So there was vascular compromise to the left half of the brain. This could have led to an ischemic stroke on the left side. But luckily our patient did not develop any neurologic signs. So that now not only is it vision threatening, it has now become life threatening also. So we took up the patient for emergency management. So the gold standard of management here is endovascular embolization and coiling of the carotidia cavernous fistula. So the right internal carotid artery was accessed through the right femoral artery, and multiple coils were used to seal the defects in the internal carotid artery. And these are the embolizing agents used. That's the dimethyl sulfoxide and squid-18, and all the fistula was sealed. And then the DSA was again repeated through the right internal carotid artery, and this time you can see there is beautiful filling of the right ACA and the right MCA. Okay. So you can compare the pre-procedure DSA. This is the pre-procedure, there was no filling on the right hand side, and post-procedure there was immediate filling of the right hand side. And what we noticed was that clinically also, immediately on the post-op day 1 itself, every ocular parameters came back to normal. The eye became quiet, the edema disappeared, the visual acuity came back to 6/6, intraocular pressure came back to normal. So the take-home message is that a high suspicion of CCF should be there when a patient presents with redness and proptosis after a head injury. DSA is the gold standard for diagnosis. Steal phenomenon should be suspected if it is a large CCF, especially if other neurological symptoms develop. And endovascular coiling and embolization is the most preferred treatment. Thank you.
After that excellent case-based discussion on the interventional radiology by Dr. Rekha, we hope to get more insights into neuroimaging.